The following program is a Town of Colonie television production of the William K. Sanford Town Library.
Hello everyone, and welcome to Health and Wellness. My name is Paul Drezelo and I'll be your host. Today we're going to be talking about skin cancer and its related issues, topics such as prevention, diagnosing, treating, as well as living with it. To help us talk about some of these topics today, we are very fortunate to have Dr. Charles Weissman, internist and oncologist at New York Oncology and Hematology. So welcome, Dr. Weissman. It's really great to have you here today.
Thanks very much, Paul. I'm happy to be here.
So I thought we'd talk about just some general topics related to skin cancer, and then if we could get into some more treatment and prevention areas, and I thought I organize a show in that way.
Sure.
Okay. So just for all of us out there, basically, what are the types of skin cancer that someone can get? The problem ones, they're all serious, obviously, but some are worse than others. So
primarily, there's three major frequent skin cancers that can occur. The common one is basal cell cancer and then squamous cell cancer. They're considered what we call non-melanoma skin cancers. And then the third one, which is the more serious disease, would be melanoma.
Right.
Basal cell cancers are generally in areas of sun exposure and occur locally. Squamous cell cancers also are a little bit more serious, but also tend to be local and easily curable by surgery,
Right.
Particularly if they're caught early. Melanoma is the more serious one.
Okay. So what typically causes all three of these? Is there a different type? How does one go about either staying away or identifying the signs of skin cancer, or how does it happen, basically?
All of these are primarily related to ultraviolet radiation exposure from the sun. And the ultraviolet radiation is composed of UVA and UVB radiation. The more ubiquitous or common is UVA, and that tends to be more responsible for the basal cells and the squamous cell cancers.
Right.
And that's related to the cumulative impact over many years.
Right.
The UVB rays tend to be more responsible for sunburns and more intense radiation, and they are more associated with occurrence of melanoma.
Okay. The melanoma happens quicker, or at the same time, it's over time also with the same?
The melanoma instance is more associated with the number of sunburns that occur at a young age, typically children, adolescents, whereas the basal cell and squamous cells are commonly in older people, over the age of 50 from cumulative sun exposure.
All right. Who is most at risk? Is it younger people, older people, both? Something that you can has nothing to do with age, or how does age factor into it?
Well, most people are at risk for basal cell and squamous cell cancers if they have a lot of sun exposure over the years. With melanoma, that's more commonly seen in people who sunburn easily, and those would be fair-skinned individuals, people with red hair, blonde hair, light-colored eyes, blue, green, and those people who freckle easily.
Okay. Once someone has or potentially comes into your office and potentially has a problem, how do you go about diagnosing all three? Basically, what do you look for? Is it?
Well, as an oncologist, I will see people who already have the diagnosis made.
Okay.
The vast majority of skin cancers are discovered by people themselves, and then they go to a dermatologist or maybe a surgeon who evaluates the lesion and does a biopsy to assess what it is.
So what does that person see before they come in? Do they see something that, how do they typically tell, like, or self-diagnose? How do they do that? Or?
Okay, and in this situation, you really have to divide up between the non-melanoma cancers and the melanoma. For the non-melanoma cancers, the usual appearance would be a nodule that is growing on the skin, more commonly in sun-exposed areas, but not necessarily.
Okay.
So it changes over time. Typically, the basal cell and squamous cell cancers are very slow growing. They are typically flesh colored,
Okay.
and usually well circumscribed. The basal cell cancers can also appear as an ulcer or a pit in the skin that doesn't heal. Anytime a lesion bleeds without trauma, that's an area of concern, or a lesion that continues to scab over repeatedly. Those are warning signs that needs to be looked at. In terms of the melanomas can be sometimes more difficult because they can have a variety of appearances. The typical melanoma arises in a pre-existing mole, but it doesn't have to.
Okay.
But most of the time it does. And it's characterized by a change over time. And this, we think of ABC. A means asymmetry, which means the lesion is not uniformly round, but it becomes more misshapen, elliptical, a change in one area of the mole. The B means for borders, so that the borders, instead of being nice and round, they become irregular and splayed out.
Okay.
And then one of the most common, or I should say most elucidating issues is coloration.
Right.
And that's where the lesion becomes colors of dark brown, black, red, violet, and those are usually very representative of melanoma.
Yeah, so I was just going to say, those are probably the ones that people pick out most of the discoloration. It's probably the quickest thing they pick up on. So once you have someone who definitely has one of the three forms, what do you usually what are the treatment options usually typically for each three?
Okay, the basal cell and the squamous cells are fairly easily taken care of, and those are usually done by the dermatologist or possibly a surgeon or plastic surgeon, and they're just locally removed, usually as an outpatient. Some lesions that are in difficult areas, such as the face, where you don't want to take a lot of skin or you don't want to create a big scar. There's something called Mohs, M-O-H surgery, and that's where a specially trained dermatologist will remove the lesion very closely around it, and then he examines sections under the microscope, and he just keeps on going until that section reveals no cancer, and he stops there. So it's a way of making sure that the cancer is removed, but limiting the amount of tissue that's taken. With the melanoma, that's a much more complicated situation. Melanomas typically are removed. They usually have a biopsy, initial biopsy, where it may just be a little shave of part of the lesion to make a diagnosis.
Right.
That's usually done by dermatology. And if it comes back melanoma, those people are often sent to a plastic surgeon who removes the melanoma. The amount of tissue removed depends on the thickness of the melanoma. And in very thin or early melanomas, it only requires maybe a ½ an inch of tissue around. But in the deeper or more advanced melanomas, it may require as much as 1.5 inches or 2 inches of tissue to be removed. And how that is closed or sutured depends on the area of the body, because there are some situations where there may not be enough skin to close the surgical site primarily because there's not enough skin. In that situation, a skin graft would have to be applied.
Okay. What about chemotherapy and radiation? Is that ever needed in melanoma situations, or is it not used as much? Or tell me something about that.
Well, treatment of melanoma, fortunately, has changed a great deal.
Okay.
Just in the last, really, 7 or 8 years. And the treatment for melanoma really depends on what we call the stage or the pathologic nature of the melanoma. And when a melanoma is removed, oftentimes that's where an oncologist like myself will see the person. Mm-hmm. And by assessing the characteristics of the melanoma, we can determine the risk. The things that we look at under the microscope from the pathologist are the thickness of the melanoma, because that determines the risk of cells getting into lymph channels or blood vessels, which can then go elsewhere. We look at whether the surface of the melanoma is ulcerated or not. Many melanomas would be just smooth, but they can become ulcerated, which we see under the microscope, and that's a more poor prognostic indicator. Okay. We also look at the number of dividing cells in the melanoma. And when we take all of those things into consideration, we determine if something called a sentinel node biopsy is necessary. And that's where we put a little dye, or the surgeon puts a little dye into the area where the melanoma is, and that dye goes to a lymph node that would drain that particular area, which would be the lymph node that would be most likely to have metastatic cells in them. And we just take that one node out and look at that pathologically. And hopefully people can be observed at that point in time if they have a low-risk melanoma. If people have a melanoma that comes back and spreads to other organs, that's where other treatment is necessary. Historically, chemotherapy has been of little use in melanoma because melanoma is not a chemosensitive disease. Okay. It can help a little, but it doesn't make any major impact on overall outcomes. Okay. In the last 7 years, there's really been a revolution in treatment of melanoma that has spread to other areas. And that's by the discovery of biologic agents. Okay. And in that amount of time recently, there's been 5 new medications that have been approved by the FDA that are significant advances in treatment. The first one I'll mention would be a medicine called ipilimumab. Okay. That's a medicine that's an antibody that basically revs up the immune system and makes it more active. And we know historically that melanoma has an association with the immune system, that in certain people, their immune system can keep a melanoma at bay. Correct. So that it doesn't progress or recur, or it may recur 10 years later. Right. So ipilimumab, in general, just revs up the immune system. And it has about a 25 to 30% chance of shrinking metastatic tumors by at least 50%. More recently, there's an even more revolutionary medicine, or medicines, I should say, that have been developed. And these are called checkpoint inhibitors. Checkpoint inhibitors are biologic medicines that are given intravenously that allow the immune system to recognize that the melanoma is there. We know that tumors of different types can produce little chemicals or molecules that will attach to the immune cells and prevent the immune cells from attaching to the tumor cells, the cancer cells. And if the immune cell doesn't attach to the tumor cell, it doesn't recognize that it's there. Right. So these checkpoint inhibitors, very interestingly, will take away these molecules that attach to the immune cells and allow the immune cells to recognize that the melanoma is there. And it's not just melanoma was the initial tumor that was shown to be amenable to these medications, but now these medicines are being shown that they are active in many different cancers. So in oncology, these are the real big discoveries of the last few years, and we'll be using these in a variety of medications, including in my own practice where we use it quite commonly in lung cancer. These immune checkpoint inhibitors are really fantastic medications. In the future, the studies are going to look at combining medicines, and there actually has been a study in which the checkpoint inhibitor, one of the checkpoint inhibitors, was combined with the ipilimumab, which is the one that revs up the immune system.
Right.
And in that study, 50% of people with metastatic disease had reduction in their tumors by 50%, and these often occurred over a period of 6 to 8 weeks. Just dramatic,
Fast, yeah.
just dramatic. And in our national meetings, when we first heard this information and saw the results of these studies, everybody was just gasping. And
Yeah.
we've never seen anything like this before. So it's been an exciting time in oncology.
So what you mentioned some of the success rates, but what are they? If someone has a diagnosis of a melanoma, what can they expect from some of the treatment options? Is there certain success rates that are well established, or not necessarily, or?
Well, again, the treatment depends on the stage of disease and where it's at. With the new medicines, even people with metastatic disease, anywhere from 20 to 30% of people can have significant remissions. And it's now being seen that maybe 10 to 15% of people will actually have no recurrence of the tumor. That person will achieve a remission and the tumor will not recur. Now it's going out for several years now. And in some of those people, they don't recur even after the medicine has been discontinued. And actually, I have a gentleman just in that category who had lung nodules from melanoma, who received treatment on a study that we did with one of the checkpoint inhibitors, and he just came back from Florida, and he has no evidence of disease, and now out over 2 years, almost 2.5 years.
Wow.
So that's why we're excited.
When you say remission, do you mean it just basically stops growing, or it actually starts to reduce it?
Remission means no evidence. Complete remission means no evidence of any detectable cancer.
Okay. The biological medicines you're talking about before, they're so new. Do you have clinical trials open to people, to newer therapies like that they could possibly try?
Absolutely, and certainly in my own practice at NYOH, we have a very active research program, both local and as part of national research organizations that we belong to, and we're very involved in testing new medications that are looking promising. In terms of the melanoma, we're now looking at combining the checkpoint inhibitors with newer medicines, new biologic medicines, to see if we can get more prolonged or more higher percentage of people responding to the medications, because unfortunately not everyone responds.
Right. With the growth of the internet, obviously over the past 15, 20 years, there's been a lot of information put out about alternative therapies and modalities, basically non-conventional medicine. Do you have any comment on that? Do you have any perspective on that, whether people, any of those actually work, or in conjunction with or outside of conventional medicine?
Yeah, that's an important topic, and it's a very large one, because when you talk about alternative medicines, there are thousands out there on the internet that people often see. The problem when we talk about alternative medicines, we're talking about medicines that people use in place of standardized medications.
Right.
And all the medicines that we use as physicians are medicines that have been approved by the FDA.
Right.
And the only way those medicines are approved is because they have gone through significant testing in which the new medicine will be compared to a standard medicine that's already in use, and the medicine will only be approved if it shows that it's better than what we have already, or as good as, and perhaps less toxic than what we have already.
Right.
So you're always comparing new medicines with old medicines, or standard medicines, I should say.
Right.
With alternative medicines, they're alternative because there's no scientific data that shows that they work.
Right. Exactly.
Just because one or two or three people say that I had a tumor and I took this medicine and I got better, that doesn't really mean that they got better from that medicine. Many times they took the medicine along with something else, or the nature of their malignancies are not really known. So it's really hard to say that because anecdotally someone took a medicine that it works. As an oncologist or as physicians, we will use anything in the world if it's been shown that it's effective.
Exactly.
And it doesn't harm people. So the only difference between alternative medicine and what we use is that we don't have any proof with the alternative medicines that they work.
Right. Well said. As an individual, before you have or potentially have a problem with something like skin cancer, what preventatively, what can someone do to help themselves not prevent any type of an incident like that, or is it preventable in some cases? Is there any steps people can take?
Absolutely, and particularly for melanoma and for the other types of non-melanoma skin cancer, the major culprit is, as you know, ultraviolet radiation.
Right.
This is mostly from the sun. Melanoma incidence has been increasing over the years because of the increase in sun exposure that people have. If you look at statistics, the risk of having melanoma in 1965 for the average person in the U.S. was 1 in 500. In the latest data that I have from 2011, for males it was 1 in 37, and in females 1 in 52.
Wow.
So you can see that it's a dramatic and significant national health problem. If we limit sun exposure, particularly in young people, that will help prevent much of the skin cancers from occurring. The use of sunscreen is important. Studies show, there's an interesting study that was done in Australia. Australia has had an epidemic of melanoma going back to the 1990s, and that's because there's a molecule in the upper atmosphere called ozone.
Right.
Ozone is a component of smog on the ground.
Yep.
Well, in the atmosphere, ozone screens out ultraviolet rays. Over Australia, there's an ozone hole, so more ultraviolet radiation gets to Australia, and therefore the incidence of melanoma in Australia was really a national health issue. So they did a study in the 1990s in which they gave, there were 1,600 people, and they gave half the group unlimited sunscreen, as much, and they were encouraged to use it on a daily basis.
Right,
Whereas
right.
the other half, they just said, do whatever you do normally.
Right.
And this went on for 4 years. At the end of 10 years, there was a 50% reduction in melanoma in the group that used the sunscreen, that was given the sunscreen.
Wow.
So it's an interesting observation. For the use of sunscreen, we recommend that people use at least a 30 sunscreen, preferably 50 or higher on facial area and sun-exposed areas. The highest risk for ultraviolet radiation is during the day between 10 and 2.
Okay.
Areas that are, or locations, obviously, that are more difficult would be in water, on sand, on snow, because you have the reflection of the sunlight, which makes it even more of a problem. And of course, summer is more intense sunlight than winter. We now have, so we encourage people to use sunscreen. You have to apply it about every 2 hours, and you have to reapply it whenever you come out of the water, because it does tend to wash off. In terms of other things you can do to protect yourself, we now have clothing that's becoming available that is very thin and comfortable, but screens out ultraviolet radiation, and a lot of the sporting goods stores have those now available. And people like who golf a lot or who are out on the beach, and for young people who are around pools, I think those are really good choices.
I know tanning salons are probably the bane of your existence, but we have to cover it since we're on this topic. What are your thoughts on? Are there any safe tanning salons? Or is there any safe way to do this, or is it just something that you're just?
Well, spray tans are okay, but no ultraviolet indoor tanning is good for you. And there have been multiple studies done showing that indoor tanning is very harmful. And every time I hear of young girls, it used to be before proms, young teenagers would go to tanning booths. Studies show that if someone utilizes indoor tanning for greater than 1 year, the risk of melanoma increases by 60%.
Wow.
If someone uses a tanning booth greater than 10 times in their lifetime, it increases by 30%.
Wow, that's not that much.
In 2009, the World Health Organization actually classified indoor tanning as a carcinogen, which means cancer-causing issue.
I didn't know it was that little. The threshold was that small to really increase your chances.
That's why
10 times over it's really not that much.
Yeah, that's why I go crazy when I hear young people
doing to themselves. Right. How does someone go about like a self-exam? What do you look for? As you mentioned, some of the discoloration before and the roughness around the edges. Is that typically what people look for if they want to be proactive about if they're in the sun more than they should be and they want to take a look at them?
I think the most important thing is to do self-examinations of your skin. Obviously, a person's back, scalp is difficult, so if you have a family member, that's always nice to have them take a look at your back. The main thing is to look for things that are changing, particularly moles. But also any kind of skin nodule that it changes over time, changes in color, starts to bleed, doesn't heal. Those are warning signs, and we already went through the signs of the melanoma.
Right. If you do have an incidence of melanoma, are you at risk of either it coming back again? Are you at a higher risk of that happening, or another melanoma happening somewhere else on your body? Is that that existing condition increase your chances for a future incident of it?
Well, that's really two questions, because the first question would be recurrence of a melanoma that someone has already had, and that really depends on the pathologic characteristics of the melanoma. And the stage, whether there's lymph node involvement or not. People with lymph node involvement have higher risks of having recurrences. The thicker melanomas, the ulcerated melanomas, they're also more risky, and those are the people that I will have return to my office on a regular basis for evaluation. If people have one melanoma, they are at increased risk of a second primary melanoma, and that's often related to that their entire skin surface has been exposed to the ultraviolet radiation that caused the first one, so other areas of the body are also at risk.
Right, exactly. If you've had skin cancer, are you at any higher risk for any type of other cancer? Like you mentioned, lymph nodes. If it went deep enough, you could develop potentially lymph cancer. Is there any other cancers that are somewhat associated with skin cancer in any way?
Not really.
Okay.
Not really. There are very rare situations where people can have certain mutations, but that's really unusual.
Okay. The biopsies, when someone comes into your office and there is an issue, can you go over some of the what's involved with a biopsy? Is there scars usually? Are there other lesions that should be other lesions around the cancer site that should have a biopsy done? How does that happen, basically, when you do that?
The typical biopsy that's done by a dermatologist is what we call a shave biopsy, where basically they just numb up the area a little bit and just shave off part of the lesion. That's for melanoma.
Right.
For a basal cell or squamous cell, they may take a little biopsy, something like what we call a punch biopsy, which is just almost like a little instrument that just takes a part of it to analyze, or if they are pretty sure they know that it's a concern, the dermatologist can just take it out surgically.
Okay, so it's pretty much an outpatient type procedure.
Yeah.
Pretty
or if there's going to be more, they'll send it to a plastic surgeon.
Okay. What about insurance? If someone comes in with a problem, they do have one of the three forms of skin cancer. How does insurance usually handle most situations?
Yeah, because these are definite health problems, almost all insurances will cover the cost of that based on the actual contract.
Okay.
That's a clear health issue, and they would cover that.
Mm-hmm. Okay, just on from your career perspective, you spent your life in this field. What have you? You talked about some of the new advances somewhat. What have you seen change from the time that you first entered the field till today? What's gotten better or worse? What's changed basically?
Well, that's really one of the great issues in oncology, and why oncology is such a great area of medicine, and that's because the science and the research are phenomenal.
Right.
And my whole career, going back to my training, was involved in, we always had research all along, looking for new treatments, doing clinical trials. And so that was a big plus for me in terms of the attractiveness of oncology. And many other branches of medicine have learned from oncology, because a lot of the science that has been done with malignancies applied to other areas of medicine as well. So that continues to be a big part of what I do every day.
So outside the biological mentioned before, is there any other big advancements that you see coming in the next 10 years or so that people can look forward to if they have a problem with skin cancer, anything coming down the road outside of the ones you mentioned?
Yeah, there are other biologic medicines that aren't necessarily involved in affecting the immune system. And because of the Genome Project and the research that's been done in identifying genes, we know that cancers are caused by mutations. Now, cells develop mutations all the time.
Right.
Most of them don't result in anything change, or the change is so great that the cell dies.
Right.
But some mutations cause activation of enzyme pathways in cells that cause the cell to grow, and is responsible for the cell being able to spread to other areas and survive. So the current research is looking at those mutations and those enzyme pathways that may be responsible for a cancer cell growing,
right,
and then developing medicines that block those enzyme pathways. And we have a number of medicines, and including some in melanoma, that are capable of doing that.
Okay. And finally, what is it about, you got into this field a long time ago, as I said, what is it about you that you like most about being an oncologist or an internist or working with cancer generally? It's obviously a very serious problem in this country, and it has been and will be. So what is it that you most like about doing your line of work and as a physician?
It was a long time ago. Unfortunately, it was a long time ago for me. But I think the attraction for oncology, I enjoyed internal medicine a lot in my training. And as a resident in training, you go through every branch, cardiology, pulmonary medicine, gastroenterology. Mm-hmm. So you get to experience everything, and went through oncology as well. The thing that attracted me about oncology is how challenging it is. And in oncology, every body system is affected.
Right.
Because cancer can affect every body system. Mm-hmm. So you really have to be aware and deal with innumerable problems that people come in with day to day. And the other thing is, because of the nature of the malignancies and the intensity, you get to be pretty close to your patients and their families.
Right.
Previously, when we didn't have very good treatment, unfortunately, it may not have been for very long in many cases.
Right.
Nowadays, many times I have people that I'm seeing for years and years, and it's not too unusual. Last week, I discharged 3 people from my office, said, "You don't need me anymore, go home and live a nice life." Mm-hmm. So, but because you're seeing people so often and the disease is such a intense one, you really get to be pretty close to the patients and their families, and that's been really rewarding.
People are living, as you said before, rather. So that's a definite.
Those are the real joys.
Right. All right. Well, I think that wraps up what we wanted to cover for today's show. I want to thank Dr. Weissman for taking time on his very busy schedule to be with us today. And I want to thank you for watching, and I hope you tune in next time for the next edition of Health and Wellness. And take care and have a really great day.